Welcome to AETCM, another episode of AETCM Emergency Medicine Channel.
Yes, you can.
So this patient is a 26-year-old male patient who studied up to BTech and working as an IT professional at Bangalore, and who is a right-handed person. So the presenting complaints was sudden onset weakness of both legs.
What is the importance of handedness in neurology case? Right hand, left hand. Is that important or not important?
Yes, it is
Huh? Why it is important? Dominant hemisphere.
So
Is that like all right-handed person? The dominance is fully on the left side. It's not like that. 80% of the people are still on the same side.
So this patient presented with a sudden onset weakness of both legs since one day, and a constricting type of pain which wraps around the lower chest since one day. So the history of presenting illness, patient was apparently normal.
Exactly tell where is the tightness present, whether it is at the level of your umbilicus, nipple, syphisternum, wherever it is.
Which was above the level of umbilicus, just above the level of
Okay.
umbilicus.
So that will correspond to
About T10.
T10. T10 is umbilicus, above
Umbilicus.
T10.
So this patient was apparently normal till that day, and he was traveling from Bangalore to his home via train, and he reached the railway station and he was sleeping there. So once he wake up, he experienced a band-like constricting type of pain involving the lower back, which wraps around his chest and abdomen anteriorly. And patient didn't had any weakness of limb at that time, and he gave history. He passed urine and stools also at that time, and he took another train to his home. And he took an auto to his home, and while he get down, he developed a sudden onset weakness of the bilateral lower limbs.
Okay. Can you tell me the reasons for sudden onset of bilateral lower limbs like this? Sudden. All of a sudden, within 5 minutes or 10 minutes.
Traumatic
Okay.
involvement of the spinal
trauma
cord.
is one of the most important things.
A stroke can be an anterior spinal artery.
Anterior spinal artery. Okay. Anterior spinal artery infarction. Okay. Transverse myelitis, it takes little more time, but okay. Transverse myelitis is another important thing. Hypokalemic periodic paralysis will not present like that. It present with all the limbs. Okay. Most important is
trauma.
myelitis. Most important is anterior spinal artery thrombosis and trauma. Will sensory loss is a part of anterior spinal artery thrombosis?
Sorry, sir?
Sensory loss is a part of anterior spinal artery thrombosis.
Yes.
Which sensation will be lost?
So pain and temperature will be lost.
Posterior column?
Will be spared in the case of
will be spared.
Yes.
Posterior spinal artery thrombosis
Dorsal column will be
will
affected.
be involved. Okay.
So this patient experienced increasing pain while lifting back from ground by bending forward, and also experienced pain on lying down. So and he had no difficulty at the time of getting inside the auto, but while reaching the destination, when he tried to step down from the auto, he experienced weakness involving both his legs, and while he trying to get down, but his knees buckled and he fell down to the ground at that time. Then he was not able to move his both legs, and he was taken to the hospital in a structure, and he was referred to here for further evaluation and management. After that, he gave history. He couldn't pass urine while he came here. So on examination, patient was alert, conscious, oriented, in time.
Difficulty in passing urine is a feature of extramedullary compression or intramedullary compression. Transverse myelitis anyway it will be there.
Yes.
Extramedullary compression, which is common. Extramedullary or
Medullary compression. I mean intramedullary.
Okay. What is the reason for that?
So there's a pathways from the brainstem to the
bladder pathways are on the middle, like
yes,
inner part of the medially located.
Yes.
Okay, correct.
So on examination, patient was alert, conscious, oriented in time, place, and person, and pulse rate was 78 per minute, and BP
what
was.
What is the importance of alertness in this case?
We can check the consciousness of the patient.
By the importance in a paraplegia patient.
So the level of the lesion can be if the spinal level is involved, then the consciousness will not be affected. So it will be spared.
Can central lesions present with paraplegia?
Yes, corticospinal.
Anterior cerebral artery thrombosis, bilateral. It's not very common, no? Unpaired anterior cerebral
internal
artery
capsule
thrombosis,
involvement.
parasagittal tumors, bleed into parasagittal tumors. They all can have altered behavior because frontal lobe is mainly involved. Otherwise, altered behavior is not a feature of paraplegia. Normal this one case.
So BP was 170 millimeters of mercury and respiratory rate of 20 per minute, saturation of 98%.
What is the importance of BP, pulse and all in this case?
So
Is it important or
yes,
not important?
Yes, sir. If it is a hemorrhagic stroke and the BP.
It's not stroke, no. It's a you are thinking about a spinal cord lesion.
Spinal cord lesion, yes.
And probably in T10.
Yes, sir.
Do you think that BP pulse examination is important in this patient or not important? Involvement of sympathetic tract can present with spinal cord lesions can present with autonomic dysfunction. Okay. So that may be up to T7 or something, but even then you have to strongly suspect autonomic dysfunction in this type of patients. At least below the level they can have hypertension, tachycardia, bradycardia. All these things are very well known in this type of patients.
So coming to nervous system examination, higher mental functions was normal. Cranial nerve examination was also normal.
Is there any vitamin deficiency can produce altered behavior, reduced vision, paraplegia?
Vitamin B12 deficiency can cause subacute combined degeneration and present with
Is it an acute problem or chronic problem? Subacute combined degeneration.
Subacute.
Okay, it is subacute. It takes some more time.
And coming to the motor system, the bulk was comparable in both sides, and tone of the muscle, both sides was normal tone. And coming to the muscle power, so the neck muscles, shoulder joint, elbow joint, wrist and fingers were of normal power, 5/5 in bilaterally. And abdominal muscles, also rising trunk against resistance was also normal.
What is it finding? Abdominal muscle?
So in case of abdominal muscles, if there is weakness below the level of umbilicus, there can be the umbilicus skin can go upwards.
What is a sign called as beaver sign?
Beaver sign. So in this patient, there was no beaver sign was absent.
Okay.
So the testing was normal. And erector spinae, I couldn't test because the patient was lying and he couldn't change the position.
So what history you can ask the patient? In that case, you are not able to examine the sexual function of the patient. What history you can ask? Early morning erections you have to ask so that that nerve roots are involved. Okay. So ideally you should ask all these things.
And hip joint power, the abduction, adduction, flexion and extension, all were 3/5 by both sides symmetrically. And knee joint extension and flexion was also involved, 3/5 power was there. The ankle joint in dorsiflexion, plantar flexion, eversion and inversion, and great toe flexion and extension, all were involved, all were 3/5 bilaterally. And coming to the superficial reflexes, abdominal reflex, the upper abdominal reflex was normal and the mid and lower abdominal reflexes were exaggerated.
Exaggerated or absent?
Exaggerated. In the lower abdomen it was exaggerated. And the cremasteric reflex was also exaggerated.
Which condition you get all superficial reflex exaggerated? Can you get any condition where we get superficial reflex are exaggerated?
In human relations.
This patient is exaggerated.
Cremasteric reflex and the lower abdominal reflex was exaggerated.
Okay.
And anal reflex was not tested, and plantar reflex or extensor response bilaterally was seen. And coming to the deep tendon reflexes, Georgia was 1+.
Here to again recheck your knowledge about superficial reflexes, which superficial reflexes, can it be exaggerated in spinal cord lesion or not.
Okay, sir.
What is your opinion? Can superficial reflexes exaggerated in a pyramidal tract lesion or not? Superficial reflexes, deep tendon reflexes are exaggerated. The integrity of superficial reflexes depend on your pyramidal tract. If pyramidal tract is absent, it will be absent. It has to be absent. That's why we diagnose at the level, below the level, all superficial reflex will be absent. But all deep tendon reflexes will be exaggerated below the level of lesion. At the level, it also will be absent. Above the lesion, everything will be present. So you have to recheck all these things. Okay.
So coming to the deep tendon reflexes, jaw jerk was 1 plus, and trapezius jerk, biceps jerk, supinator jerk, and finger flexion all were 2 plus. And coming to the knee jerk, it was 3 plus.
What is the root value of knee jerk?
L2, L3.
L2, 3, 4.
L2, L3.
L4, L2, 3, 4. Okay. That is absent.
That is 3 plus.
So that is exaggerated. That is exaggerated. Okay.
And angle jerk was also 3 plus bilaterally.
Okay.
That is also exaggerated.
Okay. What is the root value? Angle jerk?
L4, L5.
S1. Okay, it's S1.
Coming to the coordination was normal. Plantar was extensor response bilaterally.
Tell me about plantar reflex. You are a medicine PG. You tell me about plantar reflex. Babinski sign.
Yes, sir. The root value is L5S1.
Yes.
So coming to the examination, we have to place the patient in a supine position, and after checking the thumb big toe mobility, we have to fix the leg at the level of just above the level of ankle joint, and then we have to strike with a pointy object, either with a key or a tip of the knee hammer, by striking from the heel to the little toe by the through the lateral aspect, and to cross up to the mid toe.
Okay.
So the response we may get is flexion of the big toe and flexion of the other toes with the
Fanning.
adduction of the toes. That is the normal response.
What will happen to the ankle joint? What will happen to the knee joint? What will happen to the hip joint?
So the ankle joint, there can be dorsiflexion, and the knee joint there can be flexion and adduction.
Hip joint?
And in the hip joint also adduction, and there will be flexion of the tensor fascial
universal flexion response. Okay.
And tensor fascial also contracts.
Okay.
So that is the normal response.
This indicates a pyramidal tract lesion.
This is normal response we will expect. In the case of pyramidal tract lesion, there will be extensor plantar response.
Extensor response will be
seen in the pyramidal tract lesions. So in that case, that is also known as a Babinski response. There will be extension of the big toe and fanning out of the other toes. Extension of the other toes with the dorsiflexion of the foot.
Which condition you get muting of Babinski or muting of plantar response?
So in spinal shock, there won't be any response.
Diabetic patient, peripheral neuropathy. Then what will happen in cauda equina lesions?
In cauda equina lesion also there can be exaggerated
cauda equina, that is different from conus medullaris. Cauda equina is a lemon type of lesion. If the roots are involved, you get mute response. Okay. So you should know the difference between cauda equina and conus medullaris. Conus medullaris, you may get all these things. Okay.
So coming to the sensory system, the pain, light touch and temperature was decreased on the bilateral lower limbs below the level
umbilicus.
of the umbilicus.
Posterior column sensation?
So posterior column sensation, position sense was not able to test, and joint sense was normal for this patient in the lower limbs bilaterally. Vibration sense was decreased on the lower limbs.
Which is the most important sensation in posterior column? It is vibration. Once vibration is, there is a first thing to lose. Okay, so if vibration is lost, then posterior column is involved. Okay.
And coming to the cortical sensation, cortical
What is the
sensation.
sensory involvement at the level of umbilicus? At the level.
That is T10.
What is the sensory involvement in this patient?
This patient below the level of the umbilicus.
Everything is lost. At the level? Umbilicus
at the level he was not able to appreciate.
Not able to appreciate. Any hyper stimulation or increased pain for touching, anything is there? Nothing is there. So that has to be examined. So at the level it is an irritating lesion. So most of these patients will have severe burning pain at that when you touch.
When he presented, he told that a band-like pain was
But
there.
clinically nothing. Examination wise nothing. Okay.
And there was signs of meningeal irritation was also absent. Examination of skull spine, and the spine there was pain, spinal tenderness was there.
Which area?
On the lower back.
Lower back means which area?
At the level of umbilicus.
At the level of umbilicus. What is the landmark for T7?
T7.
T7.
End of the scapula.
End of the scapula. From there you have to count. You see, here you are getting a level at T10. Okay. So it may be at least 3 levels above. Okay. So somewhere below the T7 you can get a tenderness. So you have to try for that. Okay. How do you palpate spine?
We have to position the patient in a prone position, and we can make him sit up, and we have to palpate through the middle.
How do you palpate spine? This is the area emergency medicine PG should answer. How will you palpate spine? Because we deal with a lot of spine trauma. How do you manage the case with a spinal suspected trauma? This can be trauma. He was traveling in auto. There might be a previous. You have to try all these things. You have to tell properly how to palpate the spine. Log roll and what is the way of spine tenderness elicitation? Press like this. Then it will break and go inside. How do you palpate spine? Gentle means what? It should be rolling like this. You have to palpate. You should never press it. If you press it, sometimes it can break. So it should be only done very gently, like you told. Very gently. It should roll. Okay. Otherwise, sometimes it can break. Like we don't know whether it is a trauma induced by that travel, or whether suppose he's already having a lesion in the spine. Suddenly, it can aggravate. Okay. So you should never try to do sudden jerky movement of the patient. You have to log roll the patient and palpate the spine gently. Okay. These are the common mistakes done, and we'll increase the problem, and he'll become permanent paraplegic. You should be very careful in a spinal cord lesion case. If you want to do this examination, do it gently, properly. Otherwise, don't examine. You take for MRI.
And Lermite signs was negative, and other systemic examination, respiratory system examination.
What is a phenomenon sacral sparing and sacral involvement?
So the sacral involvement, sacral anesthesia, that is in the case of sensory involvement affecting the sacral area. So that is seen in the case of conus medullaris and the
extramedullary and intramedullary compression. Extramedullary, what will happen?
In a extramedullary lesions affecting this conus medullaris level or the cauda level.
You know the crossing of the fibers. Fibers will cross each segment to opposite side, no?
Yes, corticospinal tracts will cross to the opposite side.
So if the lesion is from the middle, from the opposite side, medial fibers are involved first. So the sacral area involvement is very common there. So you should know about sacral sparing, sacral anesthesia, all these things. And for trauma case also, for emergency medicine, ideally we have to check the sacral sensations in a spinal cord trauma. Okay.
So other systemic examination was within normal limits. So summarizing,
what is dissociate anesthesia in spinal cord lesion?
So
in dissociate anesthesia in emergency medicine is different. What is it? Ketamine. Okay, this is a different dissociate anesthesia. It's a sensation.
So in the case of lesions affecting the spinal cord, central part of the spinal cord, such as syringomelia, in that case there will be a low involvement of the corticospinal tract, which is crossing at the level of the lesion. So that area will be affected. So at the
what
level
is the
of
extension?
lesion,
When the syringomelia extends down or up, how the sensation will reduce?
as the lesion extends downwards, the
It goes down.
level
So this is called as
downwards.
cape-like anesthesia. It will be like a cape. Slowly it will extend, and finally the sacral area will be spared. That is the only area spared. So intramedullary lesions, sacral sparing is there, whereas extramedullary, sacral area is involved first.
Yes.
Okay, so that is very important. That's why in trauma spinal cases we check the sacral anesthesia. So that is the first thing to get involved. Okay.
So summarizing this, a 26-year-old male patient with no comorbidities, presented with paraparesis with bilateral symmetrical muscle weakness at the motor level at T12 and sensory level T10 to T12, and hyperreflexia at T11 to T12 with a bladder dysfunction and likely segmental involvement of
What
the
is the type
spinal
of bladder dysfunction you have to tell?
urinary retention.
It's a autonomic bladder, automatic bladder, UMN bladder, LMN bladder.
So this patient had a urinary retention, sir.
So what is the type of bladder involvement?
So this autonomic involvement and
Autonomic.
autonomic as well as other.
What is the difference between LMN bladder and UMN bladder? LMN bladder will be at the level of bladder fibers. So bladder will be expanding like anything. Okay. And when it is overflown, you get small amount of urine be going out. Okay. Whereas in a human bladder,
small bladder,
small amount itself, if you just touch or small stimulus is enough to void full urine out. Okay. So that difference, but most of these patients will be catheterized, so we cannot examine like that. Okay.
So this is likely a segmental involvement of spinal cord, likely at the level of T10.
Okay.
So here all the modalities of sensations are involved. I mean, motor involvement is there, sensory involvement is there, dorsal column involvement is there, as well as the autonomic fibers to the bladder is also involved. So it can be a complete.
So T10 is a sensory level. Spinal level, you have to go at least 3 segments up. There you have to focus your scan. Okay.
So we have done an MRI spine for this patient, and we have identified an extradural fusiform shaped lesion affecting at the level of T8, T9.
Is there a bleed inside the lesion?
No, sir. Okay. There was no tumor bleeding. And they advised a biopsy of the lesion to rule out malignancy.
Okay.
So the most common cause of this extradural lesion can be malignancy.
Okay.
Possibly bone mets from the lung, prostate or breast.
Okay. This T10 is a important segment in your spinal cord because it drains from the lungs. Okay. Tuberculosis, sarcoidosis, malignancies in the lung, everything go to that segment. Whereas other malignancies in like testicular malignancy, prostatic malignancy, they will be predominant in the lower spine. Okay, lumbar spine. This is a fixed area. These disc lesions are very, very rare. Only malignancies or some other tumors are very common in that area. Whereas in L4, L5, you get a lot of disc lesions. Okay.
Yes.
Now, finally, what happened?
So this patient, after this taking the MRI, his weakness and sensations actually improved.
Okay.
So weakness improved, and he got a power of 5/5, and he was able to walk up.
Okay.
So this was for a transient period only.
Okay.
So that can be due to the lesion compressive effect of the lesion.
Do you think that it is due to a compressive lesion or something else might have happened there? Is it a compressive lesion to the spine or something else might have happened? Compressive lesion is, what is the pattern of compressive myelopathy?
It's a progressive involvement.
It's a slowly progressing, or even sometimes a bleed into the tumor can acutely present with a compressive myelopathy. What is the pattern of weakness? Is it a sensory level common in that conditions?
Yes, symmetrical involvement will be the involving the.
That's okay. Very rarely it produces a symmetrical type of weakness, acute onset, and sensory levels are not at all common. It can be there, common in isolated compressive myelopathy. But whereas when it presses an artery, when it presses the anterior spinal artery or thrombosis into the artery, then the lesion can be acute.
Acute.
Okay. So how can we help the patient in acute conditions like this? So you have a compressive myelopathy. You know that it is a tumor. It may be compressing on a artery, anterior spinal cord artery. That may be the reason for weakness, because we are ruled out transverse myelitis.
Yes.
How can we give a relief to the patient immediately? So steroids are the treatment of choice. Immediately give steroids so that at least that spinal cord will be saved. Okay, if you keep for some more time, that spinal cord will be destroyed. Okay, so luckily this patient has improved. Now we have to take a biopsy and see what is this one. Have you taken X-ray?
We have taken MRI.
MRI of spine.
Spine.
X-ray chest.
X-ray chest was taken, sir.
Anything is there? Nothing was there. Okay, only it is an isolated tumor.
Isolated.
PET scan.
PET scan was normal.
Calcium was normal.
Calcium was normal.
Alkaline prostatitis.
Vitamin D was low, and calcium and ALP was normal.
Normal. Okay. Biopsy is taken or not?
Biopsy was not taken. Okay. And actually, they got discharged and they went home. Okay. And they told that they will come in OPD for further evaluation.
So ideally, we have to take a biopsy, and immediately steroids will be helpful to the patient to relieve the symptoms. Okay. So what are the types of compressive myelopathies you know? What are the types of myelopathies you know?
So there can be involvement of the whole segment, and there can be involvement of the dorsal part of the spinal cord, that is dorsal spinal cord syndrome and ventral spinal cord syndrome. Okay. And hemisection of the spinal cord, that is Brown-Sequard syndrome.
What are the reasons for paraplegia? Now you told about spinal cord. Yeah. What are the reasons for paraplegia?
Paraplegia, there can be in the case of total involvement, that is transverse myelitis. Okay. And compressive myelopathy involving the
compressive myelopathy due to intramedullary and extramedullary.
Both intramedullary and extramedullary. There can be paraplegia. Okay, then. And anterior spinal artery syndrome.
Thrombosis. Okay. Thrombosis.
There can be paraplegia.
Then. Multiple sclerosis is not isolated. Paraplegia can occur, but it is the last one to. They should have at least 2-3 times same type of lesions. What else? Non-compressive myelopathies. Non-compressive myelopathies.
Multiple sclerosis.
Okay, multiple sclerosis can present. There is a non-compressive demyelinating myelopathy.
Transverse myelitis.
Okay, what is it? Amyotrophic lateral sclerosis. Okay. Then. Polio is not a myelopathy. It's a what is it? Anterior horn cell disease. Viral myelitis. Another myelitis. Vitamin deficiency. Which vitamin deficiency?
Subacute combined
degeneration. Then any toxic material. What is
radiation-induced
myelopathy?
Latherism.
Okay, it is not common in our part, but it is common in northern sides. Okay. Then
radiation-induced myelopathy.
That is another myelopathy. Then unpaired anterior cerebral artery thrombosis, parasagittal lesions. Okay, how do you differentiate this central cause for myelopathy for peripheral cause for myelopathy? Unpaired anterior cerebral artery thrombosis. What are the differences between transverse myelitis and that? Bladder involvement. It's a different type of bladder involvement. What is the type of bladder involvement in frontal lobe lesions?
So, in the frontal lobe lesions,
it's only medicine PG should answer. Medicine PG should never answer all these things.
So, patient will lose the inhibition. That is
social inhibition. That is very important characteristic feature of this one.
He will pass
wherever you want. Okay, that is the most important point. Then paraplegia and extension flexion, you know about that.
In the case
paraplegia and extension, paraplegia and flexion. What is that? All things they'll ask you in examination. You should know about that. Complete transaction of spinal cord after sometimes patient both the lower limb will be flexed. That is paraplegia and flexion. Okay, they'll have mass reflex. What is mass reflex?
Reflexes we can by giving this reflex patient is efficient.
Correct. So that is classical feature of complete spinal cord transaction. Whereas other one is paraplegia and extension be partial spinal cord lesion. Okay. Then cauda equina and conus medullaris
medullaris syndrome.
differences.
So in the conus medullaris is at the level of L1, and once the conus medullaris ends below the L2 and L3, at the level of L2, L3, that is a cauda equina. So any lesions, any compressive lesions or other lesions affecting at the level of L1 will produce conus medullaris syndrome.
Okay.
So there will be involvement of the motor paralysis will be there, and that is sensory involvement will be produced, and sacral anesthesia, and there will be bladder involvement. In the acute case, acute involvement, there will be urinary retention, which will be followed by incontinence of the urine. So that is in the case of conus medullaris. This motor involvement can be human or element in the case of conus medullaris, but in the case of cauda equina syndrome, it will be element involvement.
It is only element lesion.
In the case of cauda equina will be only element.
Okay.
Conus medullaris can be
asymmetrical.
element. Asymmetric.
How do you manage this case in ICU? This patient will come to your ICU. What precautions you have to take? What are the things you'll do for this patient other than steroids if we make it? DVT prophylaxis is the most important thing. Then catheterization should be done. Then ulcer prophylaxis. Bed care. Okay. Then autonomic dysfunction is the most important thing we come across in this type of patient. What autonomic dysfunction you can get?
So bladder involvement will be there. Bowel and bladder.
Anyway, you are putting a catheter. We are not bothered about it. We put a catheter for till the patient improves. So patient will not be affected at all.
Bowel incontinence.
Heart rate, tachycardia can be there, bradycardia can be there. ECG can have lot of findings. ST elevation, ST depression, BP. Sometimes hypertension can be there. Sometimes, how do you manage hypotension? How do you manage hypertension? How do you manage? All these things are very important for you. How do you manage hypotension in a spinal cord lesion, GP syndrome, all these things? Fluids. Fluids can be given as a first line. What is the drug of choice in autonomic dysfunction induced hypotension? Glucagon. Dopamine will be the choice. Okay, you can give noradrenaline, but dopamine will help better than noradrenaline. In hypertension, what is the treatment?
Beta blockers.
Which beta blocker? Labetalol. That is a drug of choice. You can give any beta blocker, there is no issue. Labetalol will be the ideal drug. Okay, so these are the things we do in ICU. After some days, suppose you are seeing anterior spinal artery thrombosis, it takes at least 1 or 2 weeks to improve. What else you can do for this patient? What are the complications this patient can develop? How do you prevent the complication? Paraplegia and flexion, that is the most important thing in this physical medicine. Physiotherapy should be done to prevent
contractions.
So that has to be done. So then only the treatment is complete. Take some more, like at least 3-4 weeks to improve completely. Can tuberculosis can produce spinal artery thrombosis? Tuberculosis, one of the presentation is spinal artery thrombosis. The common presentation what we learn is port spine. What is port spine?
Involvement of the spinal vertebrae in the case of tuberculosis.
So the vertebrae can suddenly break, then they develop paraplegia. Where is the lesion? Common area of lesion tuberculosis?
Thoracolumbar.
Which segment?
Titan.
Titan is the most common area. We get TB spine, port spine. Yes. Okay. Anything else you want to add? Nothing. Okay. Thank you.
Thanks.